Hello, I'm going to talk about vasopressin as second-line vasopressor therapy. These are my disclosures and acknowledgements, none of which I think relate to what I'm going to talk about today. Now, before we talk about how to use vasopressin, I think why would we even consider using it at all? Well, to remind you from your physiology textbooks that it's a nonapeptide secreted from the posterior pituitary. And in health, it's involved in osmoregulation. It is antidiuretic hormone, ADH. And it has this action by binding to V2 receptors in the distal convoluted tubules so that the kidney hangs on to water. In shock states, though, it changes. It then becomes a powerful vasoconstrictor, binding this time to the V1 receptors on vascular smooth muscle, causing vasoconstriction. And it's the distribution of these V1 receptors that makes it an interesting compound, because there are more of these V1 receptors on the renal efferent than the afferent arterioles. If you compare that to norepinephrine, where there's equal number on both and constrict both blood vessels equally, the thought is with vasopressin, if you constrict the efferents more than the afferents, you may maintain renal blood flow better, and that may have beneficial effects on the kidney. And that's certainly been seen in the physiological studies of vasopressin in septic shock. This small study from Vancouver showing that in a small number of patients, I think it's 24, randomized to just a 4-hour infusion, a blinded infusion of vasopressin versus norepinephrine. Patients had the same blood pressure in both groups. Even with that same blood pressure, you could see urine output went up when vasopressin was started. And alongside that, there was an improvement in creatinine clearance over that 4-hour period. This was something similar was seen in this other Canadian study, looking at a similar number of patients, but now giving a longer infusion over 12 hours, but notably randomized patients to very high doses of vasopressin going up to 0.2, which I would suggest is a really high dose, but trying to avoid norepinephrine use at all in that group. You could see that there was some improvement in the SOFA score, looking at organ dysfunction over time. And when you break it down, which organ was improved, you can see it was the kidney. Here, looking at creatinine clearance again over time, and you can see in red, the top line, how when patients were treated with vasopressin, creatinine clearance improved over the 2-day period. But this is fine. These are physiological endpoints. We can see some efficacy for the drug. But what about proper effectiveness and its effect on clinical outcomes? Well, the largest trial to date of vasopressin is the VAS trial conducted out of Vancouver. And you will see in this double-blind trial where patients who already had established septic shock were randomized to vasopressin up to 0.03 units per minute versus norepinephrine. There was no difference in mortality, but the primary endpoint was 28-day mortality. When patients were followed to day 90, you could see that there was more separation in the curves. There were numerically fewer deaths with vasopressin treatment, but it wasn't statistically significant. Importantly, though, this trial did show that it seemed to be a safe treatment to give. Looking at serious adverse events, you can see very well balanced overall rates, very similar between the two treatment groups. But we followed this up looking at the patients in more detail in a post-hoc analysis, looking at renal function in particular. And we classified the patients at the time they were randomized into the degree of renal dysfunction. And we saw, using the rifle criteria, that those patients who were in the risk category, so their serum creatinine had risen by 50% from their normal baseline, did seem to have some benefit. The dark line here are the vasopressin-treated patients, and you can see their serum creatinine seems to have come down and stayed down more than those treated with norepinephrine. If you contrast that to the patients who already had more established renal injury or renal failure, you can see that there's really no separation at all. In the at-risk group, you could see that that improvement in their serum creatinine also led to almost a halving of the rate that these patients progressed to renal failure or loss. And this was roughly halving the rate of requirement for renal replacement therapy. And in that risk subgroup, you could see that also that patients who were randomized to vasopressin had a significantly lower mortality compared to those given norepinephrine. And if we think back to the original VAS trial, there was actually a predefined subgroup analysis, and that was according to the severity of shock at baseline. And you could see that the patients who had less severe shock on that less than 15 mics of norepinephrine, these were the patients where there was a statistically significant mortality benefit, both at 28 days and day 90. Whereas in comparison, those patients who had more severe shock, higher doses, there was absolutely no difference at all between the two groups. And this was supported by post-hoc analysis we were asked to do, looking at the patients when they were included. And there was a 24-hour recruitment window in this trial. And you could see that those patients who were recruited in the first 12 hours, it was maybe those patients where we saw the benefit. Whereas if you wait until the patient has become sicker, maybe got more established organ dysfunction, more severe shock, you were not seeing any benefit at all. But how can we bring these subgroups together? Importantly, many of them are post-hoc, although the less severe illness was predefined. Could it just be a chance effect? And that's certainly possible, and therefore further trials were needed. But if we were going to design that trial, could we try and learn anything and try improve the chance of success with vasopressin? And so maybe it supported giving vasopressin earlier to prevent renal failure from becoming established. Or maybe it was simply that the more severely ill patients didn't get enough vasopressin and so could benefit from higher doses. And so that was the basis of the VANISH trial that we conducted in the UK, double-blind randomized controlled trial, where we were comparing vasopressin versus norepinephrine, noting that the vasopressin went up to a higher dose. It was titrated up. So if you had more severe shock, you could get a higher dose. And in this trial, it was just over 400 patients, and our primary outcome was renal failure free days. Unfortunately, we saw no difference at all in that primary outcome of renal free days. So it didn't seem to improve outcomes, this renal failure free day outcome. But amongst the secondary outcomes we looked at, we did collect the number of patients who received renal replacement therapy. And you see that there was quite a marked difference, a nearly 10% difference, 10% less frequent use of renal replacement therapy in those randomized to vasopressin compared to norepinephrine. And you see the confidence intervals around that are just below zero, suggesting that this was quite a significant difference. Of course, the renal replacement therapy wasn't protocolized. It was up to physician discretion. But remember, the treatments were blinded, so they didn't know which drug they were given. Interesting, if you look at the duration of renal replacement therapy once it was started, it didn't differ between the two groups. Again, suggesting maybe it can prevent renal dysfunction, but it doesn't have much effect once it's already been established. The VANISH trial was supported by the Brazilian VANCS trial, this time not in sepsis, but in cardiac surgery, but using a very similar design, randomized up to vasopressin versus norepinephrine, going up to the vasopressin dose of 0.06 units per minute, so the same as VANISH, and had a composite endpoint of mortality and severe post-op complication, which you can see them listed here. Well, in this RCT, you see it hit its primary outcome with a very significant reduction in the primary outcome event, as it was a composite outcome. And when you look at what was the individual components that led to this difference, you could see it was a really marked reduction in the incidence of acute renal failure in those randomized to vasopressin. Interestingly as well, when you look at the secondary outcomes, there was a marked reduction in the rate of atrial fibrillation, which obviously we know is common in a post-cardiac population. And so I think it's interesting to go back and look at the VAS trial where we looked at the hemodynamics, and we saw that there was a reduction in heart rate in those given vasopressin. This is not surprising, maybe because you're substituting norepinephrine with vasopressin, and although we think of norepinephrine as an alpha agonist, it does have beta agonist effect. So is it simply removing that catecholamine stimulant, or is it a baroreceptor reflex response? I don't know, but it is interesting as we see heart rate reduction may be important in managing sepsis and septic shock, and particularly when we look at the results according to the more and less severe shocks groups that we looked at before, and we see this reduction in heart rate was really more pronounced in those with less severe shock. And so is this explaining some of that benefit? Well, we combined these trials I presented in an individual patient data meta-analysis. You can see the VAST, VANISH, and VANCS result, and one other study by Dr. Dunzer and colleagues. And you can see overall there is no difference in the outcomes of 28-day mortality, serious adverse events, but there is a reduction in the use of renal replacement therapy, the bottom forest plot you can see here. I think it's important to look at all of the data, and so I will point out when we looked at safety, you could see there was a signal. It's a small increase, but there was more digital ischemia in the vasopressin treated patients. But interestingly as well, there were fewer cases of arrhythmias in those given vasopressin, which, as we said, is supported by the previous physiological data I showed you. Other systematic reviews have taken place. This is for sepsis and vasodilatory shock overall. And you will see here, looking specifically for the outcome of atrial fibrillation, a really clear signal that using vasopressin compared to adding it into catecholamines rather than using catecholamines on their own leads to far lower rate of atrial fibrillation. Again, a similar signal for a reduction of renal replacement therapy use, although the confidence intervals cross 1. And similarly, this digital ischemia signal is seen there as well. But going back to the IPDMA, one advantage of such an analysis is you can look at more subgroups. And again, if we break that down into those their baseline acute kidney injury scores, and you see, again, for both 90-day mortality and the use of renal replacement therapy, those who have no acute kidney injury or the stage 1, so more at risk of renal failure, in treating these early in their disease, this seems to be where the benefit may be, rather than treating those who already have stage 2 or stage 3 AKI. So how do we bring that together? How do we use it? This is what I do now, having worked in this area for a while. I think first-line vasopressor therapy should be norepinephrine, the drug that we're all familiar with, and that makes sense. And if all's going well, nothing more needs to be done. However, if that norepinephrine dose is escalating, for me, my preferred second-line agent is vasopressin. That's what I added in. And I think the evidence suggests that it makes sense to use it earlier rather than as a late rescue therapy. And I remember when I was training, that was very much how vasopressin was used, as a last-ditch attempt. And often this is the way things work in critical care. We add new things in as a last-ditch attempt. And I'm not sure we always get the benefit. It may be too late at this stage. Exactly when should you bring it in? I don't think it's clear, and I think it's up to individual clinical judgment. Generally, for me, it's about 0.2 to 0.3 mics per kilo per minute, but it will vary. I use it particularly if I'm worried about renal dysfunction developing in the patient. And I think it makes sense if you've got problems with arrhythmias or tachycardia, rather than add antiarrhythmics, maybe just reducing the catecholamines you need by adding in vasopressin seemed to make sense to me. But I do think a caution, we need to be careful when we use high doses of vasopressors, and particularly vasopressin, and especially if you're going to use the two agents in combination. So I do think it pays to be cautious. And maybe actually the thing to do is, if you're struggling to maintain your blood pressure with these and requiring 2 high dose vasopressors, maybe we could consider lower blood pressure targets may actually be suitable for these group of patients. So I will stop there and say thank you very, very much for your attention.